Good evening, ladies and gentlemen. Welcome back to the Recovery Bank Community Education Series. For the last month or so, each Thursday night at 6 p.m., we have been privileged to offer to a limited live audience and to a much larger Facebook live audience an education series with information from local experts on topics related to substance abuse and recovery. My name is Frank Bollock. I'm privileged to be the project manager here at the Recovery Bank, which some of you may know is a peer-to-peer recovery support center located in downtown Scranton at 120 Wyoming Avenue. Our basic mission here is to connect people in recovery and to connect people in recovery with recovery resources and to help our community of family members and community at large with information regarding substance abuse and regarding recovery. We've had the benefit of really fabulous presenters over the past several weeks. Tonight is no exception. We have with us tonight Dr. Karen Arscott. Dr. Arscott, one of our staff members here, Jim McHugh, made sure that I mentioned the fact that Dr. Arscott is originally from Dunmore.
Go Bucks.
A graduate of Marywood University and the Philadelphia College of Osteopathic Medicine. Dr. Arscott has a tremendous wealth of experience in medicine, all different fields of medicine. In recent years, she worked at a medically assisted treatment clinic here in northeastern Pennsylvania, which I think inspired her passion to help people in recovery. She is a member of the faculty at the Geisinger Commonwealth Medical School and a frequent lecturer at other medical schools throughout Pennsylvania. Recently, I guess within the last year, she's undertaken a fellowship in addiction medicine and is with Geisinger Marworth, and I think pretty close to finishing up her fellowship. We are absolutely thrilled to have Dr. Arscott with us tonight to talk about addiction, substance abuse, facts about the disease, and the multiple pathways to recovery. Dr. Arscott.
Thank you. Hi, so first of all, I'd like to say I am so honored to be here tonight. This is a wonderful, wonderful place, offering a lot of support to, frankly, the people that I care about, my patients and their families. I really got into addiction, learning about addiction probably about 20 years ago, when I found out how horrible the heroin problem was in northeastern PA when I had moved back here from Philadelphia. And my husband and I started parents forums in the Abington area to try to just get the word out. I started trying to learn as much as I could about how it impacts not just the person with addiction, but the family. And so then I taught the family and addiction portion for the student assistance program for about 5 years in Lackawanna County. I think it was kind of a natural progression for me to end up in the fellowship where I am now to learn as much as possible. And people ask me all the time, why do you do that? What drew you to it? And I can say, honestly, one of the strongest draws for me was I have never met a patient population so grateful for someone caring about them. And that's the truth. So as I work with people and as I go from different place to different place, I am amazed at how many people feel the same way as I do and sincerely care about people who have a substance use disorder and their family members. And so tonight, what I'm hoping to do is show you, I believe that knowledge is power. I believe that the more that you understand this disease of addiction is going to help with the recovery process. I hope that there are family members out there, because oftentimes the family have difficulty understanding why the person, continues with this struggle. And so hopefully tonight I'll be able to shed some light on what is actually happening there. So we're going to talk about different ways to recovery, but really the recovery starts from within, and it starts from within the person with the use disorder. But what is a substance use disorder? So our DSM-5, which is how us in medicine kind of categorize all diseases and make it legitimate, and they're the codes that we talk about and such in the medical field. And you don't have to read all these, because I heard this, and I wish I remembered who it was that I heard say this, but I think it speaks it the easiest. And what he said was, a mild substance use disorder is when your substance use disorder interferes a little bit with your life. You know, like where maybe you drink a little too much and you have a hangover the next day and you're not on top of your game, or or something like that. Like where it's maybe, where you got a little, you did something, you took something, or you used something, and, made a fool of yourself somewhere or something like that. So it interferes with your life a little bit. Moderate and severe is when your life interferes with your substance use. And I'm sure a lot of you can understand what I'm saying that. So that's where your substance use disorder is actually the main focus of your life. That's when you're into a moderate or severe disease. And that's when you need need our help. You need to come and ask for help at that point. Substance use disorder and alcohol use disorder, I'm going to use those terms interchangeably. I'll use substance use as kind of the overall term, is a disease. We know it's a disease. There is no question about it being a disease at this point. It is the same as heart disease, diabetes, hypertension, all these different things like cerebrovascular disease, which causes a stroke. All these things are diseases. And the one thing that it has in common with them is that they're all chronic, progressive, and ultimately fatal, if untreated, diseases. So it's important that we understand that it is a disease. There is no question about that at this point. Now, the other thing that I'm going to talk about is languaging. So we teach at the medical school person first or patient first languaging. This is so important. Now, when I was going to school, I graduated from med school back in the 80s. And up until, I would say within just a couple of years ago, it was common, if you were in the emergency room, you'd hear the gallbladder in room 3, or the pancreatitis in room 7, or the heart attack in room 10, or whatever. And so if you went into room 3, was there just like a little gallbladder laying on the bed there? Was there a pancreas in room 7? No, there was a person with gallbladder disease, or with a pancreatitis, or with a heart attack. But there was a person there. It was a person with this disease. Same thing goes for substance use disorder. You will not hear me say addict. It bothers me to say it right now even. Because when we refer to any disease as just that disease and not as that person with the disease, we are negating every other aspect of that person's life. So if I talk about somebody as an addict, I am not talking about them as the real estate agent, or as the teacher, or as the son, or as the soccer player, or as the cheerleader, or the loving brother that they are, or the father that they are. We are negating all those other aspects of their life and focusing on their one disease, which is wrong. That is wrong. And we really need to stop talking about it as addict, alcoholic, junkie, abuser, drunk, user, dirty, clean. I hate all those words. We're going to talk about it as being in recovery, as somebody with a substance use disorder, someone with an alcohol use disorder. And if we all can start saying it that way, it is going to do wonders for us changing this and the stigma around it, and taking away those biases against people with this disease. So that's one of the things. And I always say this also. So I've been at the medical school for 8.5 years or so. And I can tell you that the medical students, not just here, but everywhere, are being taught the same thing. We are teaching across the board person or patient first languaging. And it's going to take time. But when you have an army of students coming out every year, hopefully we're going to transition all of medical care into talking about things this way. It is so important that we talk about the patient first and their disease as just part of their who they are. Just some numbers. I tried really, really hard to find numbers for 2020 because I'm going to tell you right now these numbers are all obsolete already. And we know, I think anybody who lived through 2020 knows that we've never experienced anything like that and hopefully won't ever again. But these numbers have gone up. I can tell you working in substance use disorder at Marworth and such, the stories that I've heard are unbelievable. But what's interesting to me is that alcohol has a higher number than tobacco. But overall, if we talk about substances and substance use disorder, about 60% of our population has used substances in the past month, back in 2018. So that's a lot. I could tell you that at different parts of our country, these numbers change also. So in our area, we have a fentanyl and a methamphetamine problem like I think people are just amazed at how bad it is. I'm amazed at how bad it is every day. So of the people who needed treatment, they admitted that they had a problem. This is a frightening number. 95% did not feel they needed treatment, even though when they filled out the forms, they definitely did. Now, I'm going to say, and I say this all the time to people with substance use disorder, oftentimes the reason we don't seek treatment is because we're afraid of the bias that's going to be shown to us. So what I'm going to say is, do not allow the ignorance, and I'm using that in the true sense of the word, ignorance, where we're ignorant of the facts, healthcare providers scare you away from asking for help. There are a lot of us who feel differently and want to help you. The Recovery Bank here is another place. You can get help. So there's no reason why we should have 95% feeling that they don't need treatment. We shouldn't have 3% saying they needed treatment but didn't go for treatment. We need to get people into treatment, and I think that's gonna happen if we can somehow change our attitudes, and I'm talking about healthcare, our attitudes about substance use disorder and alcohol use disorder. In 2019, this was the most recent data that I could get on this. In 2019, in the 12 to 14-year-old range, people started drinking. But I'm going to tell you, I have admitted people at Marworth who started drinking at ages 6 and 7. It's not, that's very common actually in some people. And most of the time, they got it at their homes. They got it from family members or friends of theirs' families. And I've heard all different reasons why people had their first drink. Some were curious, you know, some it was like a holiday, and so they tried it and such. And, but some of them got it, and I've heard a similar thing from many people. I'd ask them, because I don't know, the first time I tasted alcohol, I thought it tasted pretty awful. And I ask them, how'd you like it? Did you like it? And they'll say, I didn't really like the taste, but I liked the way it made me feel. And so when I'm talking to somebody, and they're like a 48-year-old man who has struggled with this disease all their life, and they tell me that at 7, they started having a beer with their dad because it was the only time that they could sit and talk to their dad. When I'm looking at that man, I'm not seeing that 48-year-old anymore. I'm seeing a 7-year-old little boy who is trying to bond with his father. And that's what makes it easy for me to take care of people with substance use disorder, because a lot of people with substance use disorder started at very young ages. And this is just some of the proof. But look at these numbers for alcohol, tobacco, and marijuana. So where did people get opiates the first time? And 50% got it from a friend or a relative, or bought it from them, or it was given to them, or they took it without somebody knowing. So if you know anybody who has opiates in their house, they need to be locked up. I've had so many young people tell me that they got it from their grandparents', medicine cabinet or their parents' medicine cabinet or something like that. And then we look on the other side, and we have 38% got prescriptions from a healthcare provider. I think we as healthcare providers have to accept that we took a part in this. We played a part in this. We played a role. I'm fortunate enough, and Mr. Bullock was talking about how I have this vast amount of experience. That's because I'm getting old, and I started in my medical field back in the 80s, so you can only get experience the longer you're around. But I've been around long enough. In the 80s, in the mid-80s, when I was an intern, we didn't have anything really to treat pain. We really didn't. We had injections and such. And I remember when the very first oral pain medicine, Roxanol, came on, and it was a little liquid where it was a couple drops of morphine. And it was about 1985, 86 when that came. And we were able to treat people who had bone pain or cancer pain or whatever with that. And it was wonderful. But then I remember how it grew. And by 90 or 91, we started getting these long-acting pain medicine. And I remember sitting there and listening to the pharmaceutical reps saying, if you use it as prescribed, you'll never get addicted to it. That's exactly what was said. And then you add into that JACO, who is the accrediting body for hospitals, making pain the fifth vital sign. There's a problem with that. Vital signs are your blood pressure, your pulse, your breathing, and your temperature. They're all measured, right? But pain was considered the fifth vital sign, and that's a subjective thing, right? So all of a sudden, nobody was ever supposed to have pain at all if you were in the hospital. I mean, that would be nice, right? But it's really not reasonable. And so what happened was doctors started giving out pain medicine to a greater degree. We started just, people started just prescribing it. And I can tell you that in about, I'm going to say somewhere between 95 and 2000, I don't remember exactly when, I had a pharmaceutical rep come to my office about Tramadol, say the exact same thing to me. You can never get addicted to Tramadol. Well, we all know that that's not true, and I knew it wasn't true at the time. But the thing is that we prescribed a lot of pain medicine. I'm trying to give a reason why. Nobody wants to see somebody in pain. Why that has continued after we knew the problem, I can't answer that. I don't have any way to get, I don't have an answer to that. These are just some more numbers, and I'm going to tell Mr. Bullock that, of course, my PowerPoint is going to be available, because I'm going to go fast through some slides so you can look at them a little closer. But really, and again, this is 2019 rather. This is all going to be blown away in 2020. Our numbers in 2020 are going to be very different. But these are still pretty big numbers when you talk about, what's going on with the opioid epidemic. We were seeing a decline in 2019. Again, though, this is going to change in 2020. I put this up only to remind me to talk about, what happens with, and it's either alcohol or opiates or anything, whatever drug you're talking about, whatever substance you're talking about. What happens is the first time you may feel really good. And then the next time you use it, you may feel really good. And you might feel okay, and you might feel pretty good. But then as you start needing to use it because you're developing a tolerance of it, and you're not getting as good a feeling from it, and then you're also developing a dependence on it where you need it more, eventually you cross over to the point where you're not using that substance anymore to feel good. You're using the substance just to feel normal. And that's when we know that there's a problem. So whenever you hit a point where you can't get through the day, you can't make it, and you're trying to just use something so that you can feel normal again, that's where you need to come and ask for help. This is important for families to understand, because everybody says, oh, they're just trying to get high, or whatever. That's not true. They're trying to feel normal. People are trying to feel normal, and that's why they continue using. And we need to work on that. So don't take notes. This is not a neuroscience lecture. The only reason I put these slides in is to lend some credibility to what I'm saying about the fact that We are now, and really we're just scratching the surface, but we are now starting to understand how the brain works, how the neuroreceptors and neurotransmitters work within the brain, and how various substances impact those neurotransmitters and neuroreceptors. So, and the different areas of the brain that control various parts of our thinking, our thought process, and our actions, and how those specific areas of the brain are impacted by various substances. So I'm going to go a little fast through this part, but I just want to show you that we are starting to figure this out. Thank goodness, right? So the limbic system is one of the big systems in the middle of our brain. It's right in the middle of our brain, and it's important for emotional context and affective response. So it's the way you respond to different things that happen to you. So did you ever notice that someone with a substance use disorder has a different way about them than maybe they did before they developed that substance use disorder, or if they're in relapse, when they were in recovery, how their emotions may have been different? That's because of this. And then within the limbic system are all these other funny named things. The prefrontal cortex is really an important part of our brain, and it's one of the main aspects of substance use disorder. It's the executive function of the brain. So it's the place where, you know, looking both ways before you cross the street may be somewhat of an executive function, right? But somebody who's under the influence of substances may just run across the street, right? Because their executive function section of their brain is no longer functioning. They can't, it's not that they're choosing to take a chance and run across the road. It's that their brain has been hijacked by these substances, and their executive function portion of their brain is not functioning properly. And this happens. I see people who do unbelievable things. Here's an example. I had, back 4 years ago or so, I had one of my patients that I'd gotten to know pretty well say to me, after I'd got to know him for a while, he said, "Doc," he goes, "can I tell you how messed up this stuff is?" I said, "Yeah, sure." I always ask my patients questions because that's where I can learn. I can learn more from them than I can learn from any book that I read. So he said, "You know," he goes, "right before I went into rehab," he said, I was using, you know, heroin, fentanyl with a friend of mine. And he said, "but we got it from different people." And he said, "my friend shot up," and he said he immediately overdosed. And he said, "I knew I was going to call 911 because I hadn't injected yet." He goes, "but before I called 911, I checked his phone to get the number of the dealer where he got it from so that I could call," he said, "so I could call and get more for myself." And he goes, "how messed up is that?" And I said, "that's pretty messed up. Your friend's overdosed right there, and you're thinking, how can you get the same stuff to use that, right?" And so I asked people that question, "did you ever do this?" And they all were like, "oh yeah, the first thing I thought of was, how could I get some of that for me?" That's a problem with executive function, right? That's a problem with executive function. And once somebody's in recovery, they can look back and say, "wow, that was really messed up, wasn't it, to think that way?" But at the time, under the influence of substances, it didn't occur to him or all these other people that I asked that that's an odd thing to do, isn't it? That would be an odd thing to do. The orbital frontal cortex and ventromedial areas are processing reward. Think about that. So again, it's the reward section of the brain that is impaired by substances. Decision making, we just talked about that also. Here's another area of the brain where decisions are being made. And then the anterior and ventral cingulate cortex are where particular behavior is handled. Now think about this. These are very specific sections of the brain, and these are all part of the limbic system and such, and the prefrontal cortex. These are all areas that are impacted directly by various substances. The basal ganglia is the motor system, and the ventral striatum is the area where motivation is translated into action. So this is the area where the focus of somebody with a substance use disorder, their focus of their day is how to get more substance. That's the area that is. That's all they think about. Like I said before, what's a moderate to severe substance use disorder according to DSM-5? It's when your daily life is interfering with your substance use disorder, because this is all you're thinking about. So how do drugs alter the neurochemicals, the neurotransmitters? So we know that there are neurotransmitters in our bodies, you know, from our brains and our nervous systems, and it's the dopamine. You may have heard of dopamine, noradrenaline, and serotonin. These are all really big, and you may have heard some of the antidepressants and such are serotonin reuptake inhibitors, SSRNAs. Some of you may hear that name. That's a neurotransmitter. It's working directly on that neurotransmitter. So let's talk about some specific substances. Alcohol. So alcohol works directly on the dopamine is a dopamine neurotransmitter. And so all of the neuroreceptors that are dopamine neuroreceptors, alcohol works on. So, and again, I'm not going to read this slide because that would be annoying to you guys. So, you know, I don't want to read it anyway. I'll let you have these slides so you can see them. But the thing is that these are areas that, the one word that I want you to catch on this is stress. And we're going to talk about this again later. Stress is a huge trigger for various substances, alcohol and opiates in particular, but alcohol stress. Stress causes the neuroreceptors and the neurotransmitters to light up. And so it's going to cause a person to want more alcohol. The chronic exposure to alcohol, and we're going to talk about this in withdrawal, alcohol withdrawal is very dangerous, which we're going to talk about. Should never stop it on your own, because it can be fatal. You can die from alcohol withdrawal. So we're going to talk about that under withdrawal a little bit. Opiates, they're throughout the brain, the opioid receptors, and the mu receptors for opioids are the exact same receptors as the alcohol receptors, which is why certain substances that we use actually can work for either alcohol or opiates. So these are, and if you look at the mu receptors, which again, alcohol and opioids are both in the mu receptors, that's analgesia, euphoria, so feeling good, respiratory depression, emesis, throwing up, antidiuretics, making you go to the bathroom a lot and maybe get dehydrated. And then the kappa receptors are in the opiates, and that's analgesia, dysphoria, which is feeling bad. And you may talk to people who, when they take an opioid of some type, have a dysphoric reaction to it. And again, diuretic. And the delta we're just learning a little bit about. We don't know that much about them yet. So cocaine binds to both dopamine, serotonin, and norepinephrine. So all of the transmitters are involved in the stimulants, so the amphetamine and the methamphetamine. And this is one of the reasons we use some stimulants to help with ADD, because they actually help with control and concentration. This I only put, it's a very busy slide, and I recognize that. But this was another one where I want to stress the word stress. Stress is a huge trigger. Every one of my patients, if I ask them every time, what do you do to manage stress? I did have one look me in the eye once and say I take drugs. That's not the answer, okay? That is not the answer. So what do you do to manage stress? And everybody's stress management is different. And you need to figure out what it is that you can do to manage. Everybody has stress. And good Lord, we know we've had a lot of stress over this last year. But it doesn't matter. When COVID's over, we're all still going to have stress. It'll be a different kind, but we'll all have stress. So I ask the patients, what do you do when you have stress? And so, you know, I've had people say, oh, you know, I take a bubble bath. And so me, if I did that, that would stress me out, because I would just sit there thinking about all the stuff I should be doing. So that would be worse for me. I walk and count my footsteps. So if you walk and count your footsteps, it's kind of a meditation. I know that at different places, probably here, you do yoga, you do meditation, you do all sorts. It is so important. I tell all my patients, have a couple things in your toolbox for dealing with stress. So important. Family members, you guys have stress too. Figure out what you can do to deal with your stress. It is so important that we manage our stress. Our society is under a lot of stress. And if everybody would just pick out 1 or 2 things that we could do to deal with stress, maybe we'd have fewer horns being blown or fewer people throwing hand signals at other people, and maybe we'd all be feeling a little bit better, and it would reduce the stress level in our country. So stress. Withdrawal. So I've never been through withdrawal. I have to be honest about that, but at the same time, I've seen patients in withdrawal, and it breaks my heart. Withdrawal is terrible. Withdrawal is hard. But we have to go through it, right? I can tell you that the only inpatient facility I have ever worked at is Marworth. Our goal at Marworth is to lessen the impact of the withdrawal. We have an armamentarium of medications and things that we can give people to help them not suffer through the withdrawal. So we will do that for you. We will do, and I know other facilities do also. I just haven't worked at them, so I'm sorry, I'm not doing a commercial. I'm just saying most facilities, if you're gonna go to an inpatient facility, ask ahead of time what they're gonna do to manage your detox. Very important. In this day and age, there's no reason to go through, a really horrible detox without getting some help. That idea goes back to the day before we understood it being a disease. That goes back to when people thought it was a choice. So let's make you suffer to get through detox. That is no longer appropriate. And almost every place I've heard of does give something for detox. But I would say if you're looking for an inpatient treatment program, ask that question ahead of time and make sure that you're going to get some comfort measures as you go through withdrawal, especially early withdrawal. So different drugs have different withdrawals. The easiest way to think about this is if the substance is something that is kind of a depressant, so like alcohol is a depressant, heroin, fentanyl, they're depressants. Opioids are depressants. So if you take anything that's going to depress your neurosystem for a period of time, and you take that for a long enough period of time, your body, your brain doesn't like to be out of balance. So it's going to charge up to try to keep you balanced. So when you take that depressant away, guess what's going to happen? There's going to be this excitatory side, right? Your body is just going to become very excited. Your nervous system's going to become excited by everything, so because it doesn't have that depressant on it anymore. If you take things to keep you to be stimulated, if you take stimulants and you take stimulants for a long period of time, and your body has been trying to tampen it down for a little bit, trying to keep you under control so you're in balance, when you take those stimulants away, you're going to be like that, flat, And so whatever it is that you're taking, I find very few, there are a couple people who take both. Most people like one or the other. And so when they take those, though, their body is going to try to balance it out. So the withdrawal is going to be the opposite of whatever substance it is that you use. So the dangerous withdrawals, alcohol and benzodiazepines, which we'll talk about, because both of those are depressants. They kind of bring you down. So your body goes into an excitatory state. So when you take that away, the excitatory state can be very dangerous. Excuse me, the length of time and the severity of the withdrawal is all going to be dependent upon how much and how long you've been using the substance. So a couple ballpark figures. Heroin, which I don't know that anybody really gets heroin anymore. I think it's all fentanyl in our area. Heroin is just so expensive. Most things, and even if you get heroin, it's going to be laced with fentanyl. But the withdrawal usually starts about 12 hours after the last dose, and it peaks 12 to 48 hours. Methadone and prescription opioids about the same. Benzodiazepines, very dangerous drug. Again, the withdrawal can be very severe, and it begins about 1 to 4 days and peaks in 2 weeks, but it can be even longer than that. I talked to somebody the other day who was having visual and auditory hallucinations 2 weeks to 3 weeks, 4 weeks after finishing their benzodiazepines. Alcohol withdrawal within 8 hours from the last drink to a few days after drinking, and it peaks 24 to 72 hours. So what are the symptoms like? And some of you know this, but family members and such may not. Opiates, physical symptoms mimic like the worst flu possible, really, really just sick. All these different, just horrible sickness, and involving about every bodily system. Alcohol, the withdrawal, again, very bad, tension, panic. Think about it, it's your body just in an excitatory state. The dangerous thing about alcohol is the delirium tremens and seizure. So people can have seizures and then have death. So alcohol withdrawal should never be attempted on your own without help. You need to have some help so you don't have a seizure and potentially die from alcohol withdrawal. Alcohol withdrawal is very serious. So I would say get help for alcohol withdrawal for sure. Benzodiazepines, that's another one. Please do not ever stop benzodiazepines cold. This is one of my very frustrating areas where I've had patients whose primary care doc has prescribed a benzodiazepine for years to them. And now, because of everything that's going on, has said, I'm not prescribing that for you anymore, and cut people off cold. I've had people tell me that. And that's frightening, because people who have been taking benzodiazepines, and that's like the Xanax and the Klonopin or the Valium for a long period of time, they could have a seizure and die from stopping benzodiazepines. So again, get help if you're going to stop a benzodiazepine. Stimulants, again, stimulants, because they have you at an excitatory state. When you stop them, you're going to just kind of crash, sleep for days, just be really tired. And the acute withdrawal can last, a couple weeks even, for cocaine. Methamphetamine and amphetamine. Methamphetamine metabolizes into amphetamine, so we use them kind of interchangeably. We have a real methamphetamine problem in our area. We have a lot of people on methamphetamine. It's a terrible drug. And when you're coming down off of that, they just feel terrible. They feel sad, helpless, depressed, really just tired, and it's again a very rough withdrawal. And methamphetamine can cause psychosis, so hallucinations, while using it, but then also in withdrawal, and so it can be very serious. There's the acute withdrawal, which can last up to a couple weeks, and then there's post-acute withdrawal syndrome, also known as PAWS. PAWS is really, it's kind of like the neurochemistry trying to get back to normal. Now, that being said, how long does PAWS last? PAWS can last, a couple months even. And I was at a conference at Penn probably about 10 years ago when I heard a professor there say that from the time of your last alcoholic drink, it'll take about 12 months for your neurotransmitters to normalize. Now, it's in phases, granted, but it'll take about 12 months. And then for opioids and other substances, it can be 18 to 24 months, with the highest risk of relapse in that last month before they normalize, for whatever reason that we do not yet understand. So when people ask me, how long is, like when they're in recovery, where are the risks? I'm going to say the risk of relapse is in the first, 2 years. And PAWS they're rough symptoms. And again, episodes can last up to 2 years, depending upon the substance. Alcohol, pretty much for 12 months. All other substances, 18 to 24 months. And this is just, how do you survive? Just be patient. And that goes for family members too, because it's going to be a hard road, but it's worth it. It's worth it to get through it. Again, I talked about this already, detox. You deserve a safe, comfortable level. The goal won't be that you'll be completely free from discomfort, but you'll get through it. And we should be able to comfort you and help you feel comfortable throughout it. Medication-assisted treatment, this is relatively new. The Suboxone and Subutex have been around for a while. Methadone's been around since, I think, the 60s. So we've had medication-assisted treatment for a long time. And I'm going to just address real quickly that it's not trading an addiction for another addiction. So addiction, by definition, is continuously doing something and getting negative consequences, but continuously doing it. So medical-assisted treatment, Suboxone, Subutex, and Methadone, are not an addiction. Now, they're a dependence, but you also don't become tolerant, so the tolerance is removed. There is a dependence, and we understand that. However, when I talk to my patients, they'll say to me, well, how long am I going to be on it? And I hate taking this and stuff like that. And I'll say, what's your goal? And ultimately, the goal is to be a healthy, productive member of society, right? So that's our goal, right? We don't want to be, robbing or, doing things and buying drugs on the street or, alcohol or, driving under the influence. We don't want to do those things. We want to be healthy, productive members of society. We want to be the father that we want to be. We want to be the mother. We want to be the husband or the wife or the brother or the sister or the son or the daughter, right? We want to be healthy, productive members of society. So if that means that you have to take a little Suboxone every day, whose business is that? And I know I'm going to get pushback on this because I always hear, and I've seen it, so I know it's true, that when you go to the doctor's office, you go to the ER, as soon as that you say you're on Suboxone, the attitudes change. I know that that's true. I don't know how to fix that. I'm just going to say that it's going to take some time for that to fix. But I'm also going to say that our ignorance, again, should not impact your life in a negative way. So if what you need to be a healthy, productive member of society is a little bit of a medication-assisted treatment, buprenorphine, naloxone, then do it. And you know what? If you will find there are plenty of doctors out there who will take care of you in a healthy, friendly way. Find them and leave the other ones behind. And I say that sincerely. So buprenorphine, naloxone, alcohol, benzodiazepines, we have naltrexone. Naltrexone you'll see is in both opiates and in alcohol, because that's the mu receptors that I talked about earlier, how those two things are the same. So naltrexone diminishes cravings. Cravings, that's like, so I heard this best. I heard a woman say once, she said, every day driving home from work, there was this billboard with this big glass of red wine on it. And every day she would go, I wish I could have that big glass of red wine. And then after about a week of naltrexone, she looked at it and said, that's a billboard with a big glass of red wine on it. And she said, she had no desire for it anymore. That was the end of her cravings. That's what cravings are. So, so we have, for opiates, we have naltrexone, and Vivitrol is the injected form of that, buprenorphine and methadone. Benzodiazepines, we don't really have anything for benzodiazepines. I know that they talk about naltrexone and Vivitrol. I haven't seen where it really works. For alcohol, we also have disulfiram, not used very often. That's the antabuse. That's the stuff that makes you really sick if you drink, if you're taking it. And acamprosate is kind of like naltrexone. It reduces cravings. It's getting a little bit better, but it was really expensive. A lot of insurance companies didn't cover it, but it works really well. But you also have to take it 3 times a day, so that's annoying to, obviously most people. Buprenorphine is an opiate partial agonist. So buprenorphine alone can create some euphoria. Buprenorphine's been around as a painkiller for a long time. So in our clinic, we have people who come to us who have chronic pain, and we convert them to Suboxone, buprenorphine, and naloxone, and they do get some relief. I mean, it's not complete because it has the naloxone in it, but it does work really well. And again, our goal is to help people be healthy members of society. And this is just about naloxone. So it just talks about how naloxone is the same as Narcan. So naloxone is an antagonist. It's a pure antagonist. So it will stop opioids from working. It binds to the receptors and it stops them from working. So we added to naloxone because we add naloxone to the buprenorphine because it reduces the possibility of abuse. This is really important. Pregnant women and breastfeeding women. So if you know a woman who's pregnant and is using substances, get her help. Do not make her go through withdrawal because that is harmful to the baby. So we do not want women to go through withdrawal. We want them to get help and maybe use the buprenorphine, naloxone, or methadone, depending upon what is going to work best for her. But she should not go through withdrawal because that will harm the baby. So that is just really, really important that everybody understand that. I talked about that. Mental illness, I'm just going to go through this really fast. How am I doing? Oh, I've got a little, okay, not too bad. All right, so mental illness, I think we all know that a lot of cases of substance use disorder come from people who have an undiagnosed or underlying mental health issue that are trying to just treat themselves and help themselves feel better. I think we've known that for a long time. And we look at the numbers, and about 8 million people or so have a substance use disorder, 21 million have a mental health issue, and about 9.5 million have both that we know of. I don't think anybody would say that we have enough mental health resources to care for all the people with mental health disorders in our world, let alone our region. We have a severe lack of resources, and we need to work on that. And I know that in the medical world, we're trying. We have some psych residencies. I know that different places have nurse practitioner programs where they specialize in psych. And so we need to do something to help with the mental health crisis that's happening in our country. Serious mental illness, this is in the 18 to 25 year range. That's just skyrocketing in 2019. Where do you think it is in 2020? I dare to get, but they're all going up, right? Every age group is going up. Suicidal thoughts and plans. This is 2009 is the blue, and the green is 2019. And, excuse me, and again, I don't know what's going to happen 2020. We already know that that the suicide rate has increased dramatically in 2020, especially in our young population. So these are pretty big numbers. Medical marijuana, I feel like I had to touch on this at least a little bit. Why are we talking about it? Because everybody's talking about it. How does it work? We're going to talk a little bit about that. What can be done, and what are the long-term side effects. So I put this in, so again, we can have this given to you, but you can just look this up. It's a map of marijuana legality by state. Back in 2016 is when our medical marijuana program went into law in Pennsylvania. And the first dispensary started in 2018, and I don't think you have to be anybody special to see the long lines outside of all our medical marijuana distribution places in this area. So who can get it? Anybody that has any of these disorders. I have to say that it's interesting that addiction is one of the disorders, but if you're in MAT, you can't get medical marijuana to treat your addiction also, because then you'd be getting two different things for the same problem. So apparently that's an insurance issue. So do I have patients in MAT who get medical marijuana? Yes, but they have to choose from one of the other illnesses. They can't use addiction as the reason. I still think that's kind of a strange one anyway, but it is approved for addiction as a substitute therapy for opioids. But again, you can't do that while you're on buprenorphine or methadone because insurance companies will not cover both things. So I think that's important. So how many people are using marijuana? I can just say a lot, but we'll put some numbers behind it. More than 12 million young adults reported using marijuana in 2018. So, and then in 2019, we know that there was a significant increase in daily use in the younger grades. And we know that, it's been there for a long time. It's one of those things also that a lot of parents and grandparents have used marijuana and think, they'll get over it. It's a different marijuana now than it was back when maybe I was a kid, or when some of like younger people, when you were a kid. The marijuana out there now is different. Plus, and I'm just going to say this now because I'm talking about medical marijuana, but we know that the marijuana in our area on the street that's being purchased illicitly is cut with fentanyl. There's PCP in it. When you buy marijuana on the street, you do not know what you're getting. And it's dangerous. And we have seen overdoses, fentanyl overdoses, from people smoking marijuana. So we need to just keep that in mind. It's not safe at all. So marijuana works on the endocannabinoid system. That's an endo means that it's within us. So we already have this system. The endocannabinoid system is part of our bodies. God put it there, but it's there. It's part of our bodies, and it's widespread throughout our bodies. And it's part of our neuro system, and so it has within it endocannabinoids. So those are, again, substances that our body makes itself. And these are just all over in our system. And there's actually CB1 and CB2. CB1 cannabinoid receptors are the most abundant. And then you have the channels and the peroxisome proliferator activator receptors. These are all part of the endocannabinoid system that's in all of us. Whether you use marijuana or don't use it, doesn't matter. We all have this system in our body, which is kind of interesting. I don't think we knew about this a long time ago, but we do now. So the CB1 receptors are in the CNS, in particular the cortex. I think you've heard that word before. The basal ganglia, the hippocampus, and the cerebellum. So most of those we heard of before. The CB2 receptors are in other parts of our body. But the CB2 receptors are the potential link with schizophrenia. We've known in medicine for a long time, and it's hard to tell what comes first, that there's a link between marijuana and schizophrenia. And I don't know that we have a good understanding of what that link is yet, but we know that there's a link there. And so we're finding out the CB2 might be the thing. And again, we're really just scratching the surface on the neuroscience system. The marijuana plant has 100 different chemicals called cannabinoids. Huh, isn't that funny? And so the main cannabinoids in medicine, in medical marijuana, are delta-9 tetrahydrocannabinol, THC, and cannabidiol, CBD. Now, some people are starting to talk about delta-8. So that's just like kind of an analog. It's another one there. Delta-8 is just another one of these cannabinoids. But you'll hear about delta-8 now too also. I've had a couple patients tell me about them. So this is on the left, the teal colored one, is the natural brain chemical. That's in your body, whether you use THC or not, that's there. That's part of the endocannabinoid system. The drug, THC, that you take in is the purple. Well, it looks a lot alike, doesn't it? So what THC is doing really is working within our own endocannabinoid system as a new transporter, as a new chemical to kind of take over that system and use it to its advantage. So exogenous cannabinoid is THC. So endocannabinoid system is what we all have in our body, whether we use anything, it's just there. And we produce our own endocannabinoids. Then we have exogenous cannabinoid, and that's THC that you get out and you buy, whether it be CBD or THC. We know that THC alters, and again, remember these names, the hippocampus, the orbital frontal cortex. So these are the areas that help with memory. So people who use marijuana may alter their memories, may cloud their memories. And it may impact complicated tasks because they don't remember how to do certain things. THC also disrupts the functioning of the cerebellum. So the cerebellum is the part of your brain that keeps you balanced. So when you're using THC, it might be that you have trouble keeping balance. And then these other posture, coordination, and reaction time are all impacted by THC. So people who have taken large amounts, we see this sometimes in our clinics, in inpatient facilities, but huge amounts, they can have hallucinations, they can have delusions, and loss of even their own personal identity. I've talked to people who've said this, who've shown me. I've talked to relatives of somebody who used a lot of marijuana, nothing else, just marijuana, and it's changed their personality. It's not benign, especially in moderate and large amounts. So this is just THC, how it works, and it's the same things as what we've already talked about, but it works in the healthy, pleasurable behaviors such as sex and eating. It just works in those centers. It stimulates the neurons of dopamine. Remember? Dopamine, that's one of the words that we've talked about a lot through this. And the flood of dopamine gives a person a sense of a high. So we can't really see this. I only put this up there to show you. Doesn't that look like the other picture? Yeah, but it's different because this is marijuana. DSM-5 has, DSM-4 did not, DSM-5 has a cannabis use disorder area. And so it's kind of the same thing. Mild use is when your cannabis use disorder interferes a little bit with your life. Moderate and severe is when your life interferes with your cannabis use disorder. So I had to add this slide in. What are we seeing about COVID and 2020? There's been 1,000% increase in calls to disaster distress helpline over 2019. There's been increases in emergency room visits. There's been increases in calls to domestic violence hotlines, child abuse, opioid overdose. The number of people that we're losing now is just unbelievable. And as I talk to my patients, and probably as you talk to people who come here, they're losing friends, from overdoses. It's terrible. Emergency housing for psychiatric patients, layoff of behavioral health people. The number of my patients who've said they've struggled with the virtual groups, virtual AA meetings and virtual NA meetings and virtual group therapy sessions, and they're struggling with it. They're on their little phone maybe or something. Or they don't have a phone. A lot of our patients don't have phones. They buy the little track phones that they can add minutes to and such, and so they've been really separated from their families, their families in AA, NA, or group therapy. So we have a real major problem that we're going to have to address as this COVID drops down. I think that we're getting the armies in place, places like this, the Recovery Bank, is wonderful. And there are a lot of us, I'm just going to say, there are a lot of us in healthcare who care about you. We care about all of you with substance use disorder. We care about your families. We feel like we're part of your families. I always tell my patients, I'm not your mother, but I'm kind of like an aunt, like that really cares about you. So we really do. There are a lot of people who care about you. If you need help, please ask for help. Please come out and ask for help. There is somebody around who is willing to help you with whatever it is you're struggling with. The other thing is, I'm going to just say it one last time, is figure out what you can do to manage stress. Stress is what causes relapse. Stress is the biggest trigger that I've seen. So stress, figure out what you can do to manage your stress and reach out for help. And I always tell my patients also, I say, if you start thinking along the lines of relapse, and relapse happens here before it happens anywhere else, who are you going to call? I have had people say Ghostbusters, but that's not true. Ghostbusters aren't going to help you. Who are you going to call? Have a plan. Have it ready. Talk to that person ahead of time. I don't care, it doesn't, it can be a sponsor, it can be anybody else, it could be somebody, a friend, anybody that you can talk to, but plan it out and ask them. And I always say, I played I played softball most of my life, and I've been a coach for softball. You can't wait until the ball's in your hand to figure out where to throw it, right? You got to think of what you're going to do with that ball before it's hit so that you don't take that minute. So I want you all to think of what you're going to do if that nasty little relapse thing starts, that trigger starts clicking off in your brain. Who are you going to call? Where are you going to get help? So reach out for help. Three things that I'm going to leave you with. Reach out and get help. Number 2, have a plan for stress. Deal with your stress. And number 3, have somebody on your side, on your team, ready to get a call from you if you need them. God bless you. I hope you're all well. And if you have any questions, please send them into the Recovery Bank. They'll get them to me, and I will answer them as best as I can. And it was a pleasure. Thank you so much. Take care.